We have introduction about abdominal trauma. Abdominal trauma constitute about 7 to 10% of hospital admission and about 20% of all trauma surgery. 3/4 of this attributed to the RTA, car accident. And 2/3 occur in male with peak incidence of age about 14 to 30 years old. Those people is active people and common in male and uncommon in female على اعتبار انه الميل more active than female regarding the work, job, okay, especially in this age group. Penetrating injury has a higher mortality rate of up to 12% and account for 1/3 of all abdominal trauma. So the blunt abdominal trauma more common than penetrating abdominal trauma. Gunshot stab wound account for 90% of penetrating trauma. عادة الستاب wound والgunshot تشكل الجزء الأكبر من penetrating trauma. 50% of preventive trauma death are related to inappropriate management of the abdominal trauma. So our job to prevent this percent of preventive death. Okay. Another percent is occur at the onset of the trauma. So the intervention, our intervention have no or little benefit of them. So preventive death is about 50%. Abdominal injuries should be suspected in all trauma patients. This means we should suspect abdominal trauma in all the injuries. Suppose your patient have head injury or fall from height, and we suspect there is spine injury or head injury in this patient. So we should exclude abdominal trauma or abdominal injuries in all type of the trauma. This represents there is no anatomical cut of the trauma, or there is no anatomical differentiation of the trauma, because the trauma cannot differentiate between chest and abdomen. Okay, so called torso injury. Torso means injury to the chest, injury to the abdomen of the trunk. Okay, because there is in a trauma there is no anatomical variation. For example, when we suspect or when we suppose the patient have splenic injury, and you should suspect there is fracture to the lower ribs, and you should suspect diaphragmatic injury with the splenic injury, and we should suspect there is hemothorax, especially left side hemothorax. So there is no differentiation between the anatomical differentiation in the trauma. Abdominal trauma classification, we classify abdominal trauma to penetrating abdominal trauma or blunt abdominal trauma. Penetrating divided to high velocity injury and low velocity injury, especially gunshot wound. Okay, and another class of penetrating injury, stab wound. 1/3 do not penetrate the peritoneum, and 50% need surgery. The stab wound, 1/3 of them have no penetrate the peritoneum. It is superficial to the abdominal wall, skin subcutaneous tissue to the muscle, but it is not penetrate the abdominal peritoneum. So 50% need no surgery. Blunt trauma, it is high energy transfers, car accident, for example, or low energy transfers, for example, fall from height, fight, blunt trauma. Okay. واضح صوتي شباب؟ سمعوني زين؟
اي دكتور واضح.
واضح دكتور.
تمام. We discuss blunt injury. The blunt injury, splenic injury, represent the most common organ or solid organ injury, about 25%. Liver injury to the less especially in young age group, about 15%. Hollow viscous injury like small bowel or large bowel, about 15%. Kidney injury, about 12%. And retroperitoneal space or organ, it is very important to evaluate and not miss the retroperitoneal injury, because it is give equivocal physical examination, and even by simple investigation will be missed. Retroperitoneal organ, about 13%. Mesenteric injury, about 5%. Okay, not you should know about mechanism of injury of the abdominal blunt injury. We have compression, we have crushing injury or shearing injury or avulsion. These four types of mechanism of injury of the blunt abdominal trauma. Evaluation of the abdominal trauma, we start by primary survey and secondary survey according to the ATLS. طبعا ATLS, this is a system of management of the abdominal trauma. معتمد هذا اللي هو start by primary survey. Primary survey initial assessment and recitation should be simultaneous. What I mean by simultaneous? Simultaneous, it is when we taking a primary survey to assess ABC, we should have recitation at the same time. We should give order to the other staff to put a cannula while we assess the ABC. Principle of ABCDE should be applied in any trauma patient. Adequate airway, breathing, treating the circulation, hypovolemia, and disability, to assess the neurological status of the patient rapidly. قل له ارفع رجلك، شو اسمك، تحرك. Okay, this is the rapid Glasgow Coma scale analysis. Okay, and E بالاخير اللي هو exposure. We should expose the patient to not miss the injury elsewhere, for example in the back, in the thigh, in the gluteal region. Should have adequate exposure for any patient with a trauma. At the same time, should be insert a wide bore cannula, okay, IV cannula, where an initial fluid resuscitation, rapid infusion of 2 liters of the crystalloid solution, especially normal saline, followed by colloid if necessary. We use normal saline better than Ringer solution to exclude or to prevent to cause metabolic acidosis to the patient. We choose the normal saline in the trauma طبعا. Continuous monitoring of the blood pressure, pulse rate, oxygen saturation to the patient. نخلي البيشنت على chart to continuous monitoring or charting. Rule out other injury. You should rule out another injury before the beginning of the secondary survey. Secondary survey start by amble, and we ask about the mechanism of injury. Mechanism of injury, you should ask about it in the secondary survey. ما تحكي المريض إلا بالأي بي سي ودي وسوي لها recitation والبرايمري survey، بعدين تاخذ معلومات من المريض about mechanism of injury and amble. Regarding the mechanism of injury, you should know the speed of the vehicle. You should know the type of collision. You know about vehicle intrusion into passenger compartment, type of restraint, deployment of airbag, patient position in the vehicle, وين قاعد يابا بالمقدمة بالأخير، نستخدم البيلت لو ما مستخدم البيلت. اوكي، هذا إذا داخل السيارة. ممكن outside the car، ممكن المريض هو outside the car. اوكي، هاي كلها تعرف الميكانيزم. Sometimes we know the type of injury from the mechanism. Suppose the patient in the front beside the driver and use the belt. You should suspect the duodenal injury and pancreatic injury, okay, from the type of the mechanism of the injury. Then ask about amble. Amble mean allergies. Should ask about any allergy to the drug, any allergy to the food, because the patient may need surgery, okay, and use of these drugs. Medication, any patient taking already taking medication like beta blockers, warfarin, okay, anti-diabetic drugs. P, previous medical history is very important, because any patient have previous surgery, any complication in this surgery, or any anesthetic difficulties, okay, in these previous surgeries. Last meal time, you should ask about the last meal to the patient. Event surrounding the incidents, for example, any loss of consciousness and immediate to the injury. هاي كلش مهمة. We ask about, even it is not ask the patient, ممكن ask the next of kin اللي مسعفين اللي جايبينه من الطريق. Okay. Examine each body organ meticulously. يعني you should examine thorough examination of the patient from the toe to the bottom. Physical examination, you should examine the patient about bruises and abrasion over the abdomen, self-pelt sign or self-pelt mark. If it is present, abdominal pain or tenderness, when there is localized abdominal pain or tenderness, absence of the bowel sound, we should auscultate the abdomen, palpation about the rebound tenderness when there is hollow viscous injury. Some patient may come with acute abdomen, rigid abdomen, because hollow viscous injury. Gardening, any distension, any sign of pregnancy, any sign of pelvic instability. We concentrate about these four things regarding rebound tenderness, gardening, pregnancy, pelvic instability, okay? And not miss the rectal examination in the secondary survey, because rectal examination may give idea about rectal injury, especially extraperitoneal rectal injury. In this situation, the patient came with a soft abdomen because it is have extraperitoneal rectal injury. So rectal examination is important to rule out any blood in the finger. And when there is blood, it means there is rectal injury, may need surgery and intervention. And by rectal examination may assess high reading prostate. That means prostatic urethral injury, okay? Rectal tone, and vaginal examination. Gluteal fold should be examined, because penetrating injury to the gluteal region means abdominal injury, even with soft abdomen. After that, we have should tube insertion regarding urinary catheter or gastric tube. Urinary catheter, it is benefit about monitoring of the urinary output, and there is caution to use Foley catheter, especially when there is inability to void. Ask the patient to void. If it is inability to void, you should suspect urethral injury and pelvic fracture, blood at the meatus, scrotal ecchymosis, high reading prostate during BR examination. These 5 points to suspicion of urethral injury. So have a precaution about the use of Foley catheter. Another, you should put a gastric tube or NG tube to relieve any distension and decrease risk of unattended vomiting, but it can be reduced, induce the vomiting sometime. And avoid the risk of aspiration, especially when laparotomy and anesthesia used. And at the beginning of anesthesia, use mask anesthesia, and the patient when it have a full stomach may induce vomiting and aspiration injury and risk of aspiration if the patient have no NG tube. Caution to use gastric tube when there is a facial fracture or basal skull fracture, may induce more injury to the brain when the patient have basal skull fracture. Abdominal trauma evaluation by physical examination. The situation, sometimes the physical examination is unreliable and have no benefit. Physical examination, what are these situations? When the patient have head trauma and disturbed level of consciousness, the abdominal examination have it is unreliable and have no benefits. Spinal cord injury, alcohol intoxication, when the patient have alcoholic at the time of acute intoxication, so the abdominal examination is unreliable. Use of illicit drugs, sometimes the patient have addict about the illicit drugs, so the use of this examination have no benefit. Injury to the adjacent structure, sometimes when the patient have fractured ribs or or painful lesion around the abdomen, there is spasm to the abdominal wall, so the abdominal examination have no benefit. Significant amount of the blood present, sometimes the patient have high amount of blood in the peritoneum, so the abdominal examination just distension, but there is no sign of gardening or rigidity because the blood is less irritant to the abdominal or peritoneum. Use of analgesia. When the patient use of analgesia, patient sometimes have no pain, no gardening. You should not use the analgesia in patient with acute trauma. What are the investigation to the abdominal trauma? طبعا investigation, the direction of investigation depend on two important things اللي هي hemodynamical stability of the patient. What is the hemodynamic status of the patient? If it is stable, we need investigation. If it is not stable, may need surgery without investigation. In hemodynamical stable patient, we start by full blood count and blood gas, urea and electrolyte, and imaging. The first imaging is fast, DBL, CT scan of the abdomen, and laparoscopy. We discuss each one separately. Regarding the most important imaging of the abdominal trauma is fast, اللي هو focused abdominal sonography of the trauma. Detect free fluid in the peritoneal cavity, non-invasive and rapid, have high specificity and sensitivity, about 90% and 97% is accurate. Demonstrate presence of the free intraperitoneal fluid اللي هو عادة يكون blood, and evaluate the solid organ hematoma, but not give the detail about the solid organ injury. Advantage, it is have no risk for contrast media or radiation like CT scan. Rapid, portable, non-invasive, ability to repeat exam, and bedside. We can use use to the patient at the bedside. So because it is portable, but have disadvantage about it cannot assess the hollow visceral perforation and operator dependent. تعتمد على اللي يسوي. ممكن يقول لك يا بتر هذا ماكو فري فلويد في حين هو اكو فري فلويد, but the detector or the detector does not detect the free blood or free peritoneal fluid. Retroperitoneal structure cannot be visualized by ultrasound. It cannot be detected by ultrasound. In the past, we assessed 4-view technique. We detect the Morrison pouch, hepatorenal pouch, Douglas pouch, left upper quadrant, splenic view, epigastric view اللي هو pericardium view. The first one Morrison pouch اللي هو حسب ما تشوفونها بالصورة بين الليفر والرينال اللي هو هاي واضحة جدا. هذا الليفر وهاي الرينال وهذا اللي هنا الفري فلويد الموجود اللي هو the most sensitive space for any free fluid. يعني اول ما يبدي فري فلويد بالتروما بالاكوت ابدومن يصير فلويد in this area. DBL اللي هو diagnostic peritoneal lavage have sensitive high sensitivity for detecting intra-abdominal bleeding about 98%, but does not detect the diaphragmatic injury. Poor at detecting retroperitoneal bleed. Invasive procedure. إذا تتذكرون شلون يسوونه by local anesthesia, incision, supraumbilical incision. We use the needle for aspiration at the start. When it is come blood, frank blood, so it is positive. And when there is no frank blood, we introduce about 1 liter of lactated Ringer solution to the abdominal cavity and leave in the abdomen. And after a period, we deflate this irrigated fluid to the urine bag and examine the irrigated fluid for RBC, YPC, and amylase, and presence of bile, presence of the fecal material. Okay, so the positive criteria of the DBL when the RBC in the irrigated fluid about 10^5 cell per cubic millimeter, or YPC count about 500 cell, more than 500 cell per cubic millimeter, amylase level more than 175 unit per mil العفو, presence of the fecal material, so it is positive, presence of the bile, and 10 mil of the frank blood, so it is positive for intra-abdominal injury. There is contraindication for DBL, absolute contraindication when there is peritonitis or unstable patient, injured diaphragm, extraluminal air by X-ray, significant intra-abdominal injury by CT scan, and intraperitoneal perforation of the bladder by cystography. A relative contraindication when there is a previous abdominal operation because adhesion, and so risk of injury while introduce the catheter. Morbid obesity is very difficult to do DBL. Gravid uterus, especially in third trimester or second trimester, it is very difficult to use catheter supraumbilical in presence of gravid uterus. Advanced cirrhosis because there is risk of bleeding due to portal hypertension and the presence of the portosystemic shunting around the umbilicus caput medusa. Pre-existing coagulopathy is relative contraindication for DBL. Another diagnosis test هو CT scan. CT scan is very important, and now replacing the DBL. طبعا DBL هسه ما حد يستخدمه because the availability of the CT scan, sensitivity مالته very high in detecting intraperitoneal bleeding بين قوسين fluid. Contrast enhanced CT scan give useful anatomical and functional information about organ injury. So have a give detail about solid organ injury. الفاست give idea about the solid organ, but the CT scan give detail and grading of the solid organ injury. Can identify organ injury and may be used to determine which injury can be managed conservative in a stable patient. Useful in grading solid organ injury مثل ما قلنا, especially liver, spleen, renal. Okay. Another modality to diagnosis of the abdominal trauma is laparoscopy. Increasing use in assessing trauma, useful in detecting the peritoneal penetration and identifying diaphragmatic injury. Also can be used for treatment of the certain injuries. Suppose the patient have liver injury and small laceration of the liver injury, we can treat it by laparoscopy, and sometimes even splenic injury, splenectomy in special cases can do by laparoscopy. This is algorithm for abdominal trauma. When abdominal trauma by gunshot may mandate laparotomy and stab wound when there is evisceration, يعني معناها when the bowel get out the abdomen, positive DBL, hemodynamically unstable, peritonitis need laparotomy. Blunt abdominal trauma we classify it to unstable hemodynamically or stable hemodynamically. When the patient is stable hemodynamically, we use investigation in form of CT scan, fast, DBL, and according to investigation and hemodynamical stability of the patient, after that may need to continue conservative treatment or laparotomy. If the patient have blunt abdominal trauma and unstable, we should go to the laparotomy. Other other investigation in the abdominal trauma like urethroplasty, cystography, IVB for hematuria, may need IV contrast, but you should keep a good urinary output before using IV contrast. Better use of CT scan instead of them, because availability of the CT and sensitivity of the CT scan to detect the organ injury. Spine fracture, chance of the fracture should be excluded in any abdominal trauma patient. We discussed the small intestinal trauma and from the solid organ injury, splenic injury. And the small intestinal injury, it is constitute about 15% of all laparotomy of the trauma. High index of suspicion required in any case of abdominal trauma and have small intestinal injury. عادة يكون يجي المريض have gardening and acute abdomen, even it is hemodynamically stable patient, because small intestinal injury gives some sort of the peritonitis. Serial examination is very important, because at the beginning of the injury, the patient sometimes have normal examination, while after that we have gardening or acute abdomen. So when any case of the abdominal trauma and have small intestinal injury, should have admission for serial examination, not excluded by the first examination. DBL diagnostic in 95%, increasing success with the CT and laparoscopic use to detect the small bowel injury. Delay in diagnosis increase morbidity and mortality rate, because when we assess the abdominal trauma, especially blunt abdominal trauma, at the first the patient is stable, abdomen have no gardening, but after that, after hours, especially when it is discharged home, the patient become acute abdomen and gardening. So not discharge the patient with abdominal trauma if you suspect small intestinal injury. خلي عندك برتها وسوي له monitoring of the abdominal examination، لأن ورا ساعات يصير acute abdomen. Splenic injury, 20%, more than 20% of the splenic injury occur inadvertently during other abdominal operation. Sometimes splenic injury is occur during other operations like gastrectomy or surgery of the tail of pancreas, also surgery to the adrenal glands. So there is may have iatrogenic injury to the spleen. On some patients, spontaneous rupture can occur following trivial trauma, especially when the patient have severe splenomegaly in case of malaria or infectious mononucleosis, may have spontaneous rupture of the spleen other than trauma. Clinical feature depend on the degree of the hypovolemia and the presence of the associated injury. When there is mild trauma to the spleen, may have mild degree of hypovolemia and the patient hemodynamically stable. If have a high grade of splenic injury, patient may have hypovolemic shock or acute abdomen. The presence of the associated injury, like for example, nearby structure like stomach, the patient come with acute abdomen, not from the splenic injury, but from the stomach injury. Clinical feature range from left upper quadrant pain to the shock state and peritonitis. 30 to 60% of the patient will have other intraperitoneal injury مثل ما قلت لكم nearby structure like liver, العفو, stomach, tail of pancreas, renal injury. Blunt trauma, chest or abdominal trauma, hemodynamical stability, left upper quadrant pain, lower rib fracture, left shoulder pain, called positive Thi-Qar sign. CT scan will save about 70% of the spleen. We need to observe the patient with the splenic injury and have stable hemodynamically up to 72 hours. Need admission and observation. But the healing period of the splenic injury after conservative treatment need about weeks to treat completely. Not missed or complication of post splenectomy complication, especially post splenectomy infection. Okay, اللي هو طبعا increase in children and the incidence of occurrence of OPSI about 1%. Investigation about the splenic injury fast ultrasound to the abdomen, DBL, X-ray اللي هو عادة enlargement of the splenic shadow, و CT is very important to assess splenic injury, especially grading when grade 1, 2, 3, 4 of the splenic injury. Grade 1 mean minor subcapsular tear or hematoma. Minor هو أقل من 1 cm. Grade 2 parenchymal injury not exceeding to the hilum and laceration is 1 إلى 3 cm in depth. Grade 3 major parenchymal injury involving vessel and hilum. Grade 4 shattered spleen. There is main vascular injury of the spleen. Treatment of the splenic injury. If cardiovascularity, the unstable patient require rapid resuscitation and early surgery. If hemodynamically stable patient, consider either by ultrasound, CT scan and grading, and may treat conservatively according to the hemodynamical stability of the patient. If hemodynamically stable patient, we can observe the patient with the splenic injury by conservative treatment. This CT scan with the splenic injury, هذا الليفر وهذا السبلين جاي تشوفونه وهذا البلد يكون شكله بهاي الصورة. surgical option طبعا مو كل surgery يعني معناها splenectomy. Surgical management can involve either splenectomy or splenic repair, but sometimes there is the splenectomy is a wise decision for unstable patient because splenic repair take time, and sometimes the patient condition not withstand this detailed treatment or detailed repair of the splenic injury. So the splenectomy is sometimes a wise decision for surgeon. Main benefit of retaining the spleen is prevention of the post-splenectomy infection. If splenic conservation attempted need to preserve more than 20% of the tissue of the spleen. Indication for non-operative treatment: when the presentation more than 12 hours, hemodynamically stable patient, no sign of the abdominal injury, other abdominal injury مثل ما قلت لكم، يعني no sign of peritonitis or acute abdomen. Ultrasound CT scan follow up is present، يعني لازم عندك facilities for CT scan for ultrasound to follow patient. مو انت مثلا مستشفى بريفري وما عندك هاي facilities وتخلي البيشنت او ذا سبلينيك انجري كونزرفتيف تريتمنت. ماكو هيك كلام. كلوز مونيتورنج فور بيشنت وذ كونزرفتيف تريتمنت لازم موجود. Conservative management: overall 20 for 40% of the patient are suitable for conservative management. Children can often be managed conservatively as they have increased proportion of low-grade injury, fewer multiple injuries, should be monitored in high dependence unit, and require cardiovascular and hematological monitoring to the patient. If successful, patient should remain on bed rest for 72 hours, limited physical activity for 6 weeks مثل ما قلنا to complete healing of the splenic injury, no contact sport for 6 months, surgery need if clinically hypovolemic of they have falling hematocrit. Approximately 30% of the patient fail conservative management usually occur within first 72 hours of the injury. عادة الفيلر of conservative treatment of the splenic injury تصير أول 3 أيام. Failure of conservative management often result in splenectomy. Eye picture of splenic injury. What is the new in the abdominal trauma? Diagnostic CT, ultrasound, laparoscopy have important or impact on the is coming. طبعا laparoscopic treatment of the abdominal trauma هسه حاليا احنا بدينا بيها قبل فترة، و even splenectomy can do by laparoscopy. Therapeutic non-operative management of the spleen and liver with blunt abdominal trauma. Non-operative for liver gunshot is starting، وهاي خلوا عليها علامة انه there is chance of non-operative treatment for liver injury of the gunshot. If there is isolated liver injury of the gunshot can be managed by conservative treatment. بس بيها شروط. Damage control laparotomy is very important, and abdominal compartment syndrome بأني انتم تقروهن عليكم. اللي عنده سؤال يسأل شباب.